Very good afternoon to all of you. You're very welcome to this week's session. Every other week, we meet to remind ourselves and refresh our knowledge of managing different emergencies. And this week, we are delving deep into headaches and stroke. And we have experts with us that are going to share. And the session shall also have a time slot for you to send in questions or any inquiries. So we shall start with introductions of the different experts that we have. I'll start from my left. Just introduce yourself to the listeners.
Okay.
Start with them.
Hello, I'm Sister Nabwanika Diana. I work with Nakuru Regional Referral Hospital. Yes, with ICU department.
Thank you.
Okay, thank you very much. I'm called David Wamala. I'm internal medicine physician, and I work in the medical emergency unit of Mulago National Referral Hospital.
Thank you so much.
Hi, I'm Mary Ellen Lyon. I'm called Mary Ellen Lyon. I'm an emergency medicine physician, and I teach emergency medicine at Makerere University, and then work at Mulago Hospital in the various emergency departments there.
And I'm Dr. David Muganzi, and I will be today's moderator, taking you through the session. I am an intern at St. Francis Hospital, Nsambya. So to start with, we have a pre-test that we are supposed to take. This is to help us grade how much we are getting from this session. So the link for the test is going to be shared in the chat. It takes a very few minutes, so let us all participate in the pre-test. As we take off a few minutes to do the pre-test, I'll just want to hear from the people online the expectations for this session. You can share in the chat what you expect from this session, or if you would like to unmute, you can raise your hand and then share with us briefly. As we participate in the pre-test, I'll start with sharing my expectations, and then I'll let my colleagues on the panel here also share the expectations. First of all, I expect to get refreshed in the management of stroke and identify the different cues that will get us to take certain lines of management over others, and I expect to have a discussion into life experiences from our experts. So I will go to Diana.
I expect to add more knowledge on what I've been knowing, more so in the ED department. I think that's what I can say.
Okay, thank you so much. Yes, Doctor.
Yes, thank you. So for me, I would expect to have a discussion amongst my colleagues here, and also from the people who are online, because I believe some of them know more than we do. I would like to learn. There are some very good topics here. Nursing of a patient who has got a stroke, managing headache and stroke, because these are very, very common things in our setting. So I expect to be better by the time I leave this place. Thank you.
All right, and then
Yes, hello. I'm much the same way. I'm looking forward to hearing the different perspectives. I'm always interested in the range of experience and type of provider and workspace that these echo sessions provide. So interested both in the presentation of headache and that kind of parsing what's going on there and the management, and also stroke. Once we looks like we feel fairly certain that a patient has stroke, just the different approaches and ultimately the management of it. I'm just looking forward to sort of the range of experience and perhaps hearing from some of you all what you're seeing in your particular practice location when it comes to either a my head hurts or more of a specifically stroke presentation.
okay, all right, thank you so much. We have some of our one of our presenters online. I would like to request him to introduce himself and share his expectations from this session. Dr. Mujuni Daniel, if you're able to unmute and introduce yourself.
Yes, thank you everyone. Good afternoon. I am Dr. Mujuni Daniel, a junior house officer at Mulago National Referral Hospital. I'm going to be doing a case presentation for this topic. I expect to learn a lot more about management of strokes and especially pain management for patients who come in with headaches, just general headaches, not associated with the strokes specifically, but just headaches. Thank you so much.
All right, thank you so much. If we have Dr. Kaddu. All right, so I hope we have all taken the pre-tests and our expectations are laid out. If you have not taken the pre-test, please go ahead and tap the poll. There's a button for the pre-test. Take it, and just less than 2 minutes, you should be able to submit, and then we start the session. As you have heard, the expectations are laid out from our side, and if you can, please share in the chat what you expect from this. Our agenda today has, we shall have a case presentation by Dr. Mujuni, and then we shall have a reaction to the case presentation. I hope we all participate actively in that. And then we shall have a presentation on the different causes of headache from Dr. Wamala David. And then we shall have a presentation on assessment and investigation of patients with headache by Dr. Mary Ellen. And then we shall have a presentation on nursing a patient with a stroke by Sister Diana, and then we shall have a presentation on management of headaches and stroke by Dr. Kaddu Mukasa, together with Dr. Mary Ellen. And then we shall delve into the discussion, the Q&A, where we want to get your experiences in the field as different health practitioners, from where you are, how you been managing this and how patients are presenting in your area and how differently you're doing things probably. And then we shall have a post test and take a screenshot with that. So I think we are due to start our session with a case presentation. We ready for that? All right, yes. So I will hand it over to Dr. Mujuni to start the case presentation.
Okay, so good afternoon, everyone, once again. I am going to present a case on headaches and stroke. As we wait for the slides to be loaded. So I've just started my internship. I said my internship two months ago, yes. But we have started to see an increase in the number of strokes, especially in young males. We're going to look into why this is happening, and we shall probably publish something about it soon. Okay. Okay. So I'm presenting a 45-year-old male. He's a known hypertensive for the past 3 years. I don't know. Are we able to see the slides?
No. Then, Dr. Daniel, we are working on it, but you can proceed.
So I'm presenting a 45-year-old male, a known hypertensive for the past 3 years on amlodipine 10 milligrams, telmisartan H80, stroke 12.5, atorvastatin 20 milligrams, but he reported poor drug adherence. He's not a diabetic. He presented with a 4-day history of severe headache of sudden onset, constant and throbbing in nature. Now, this headache was involving only the frontal and the parietal regions of the brain. It was associated with blurred vision, not relieved by any pain medication, aggravated by bright light. He did not report any muscle weakness, no slurring of speech. He did not report any episodes of reduced level of consciousness or loss of consciousness or even fits. He has no history of trauma, no history of alcohol use, no history of smoking, but he, however, reported that this was his second admission. The first one was at Mengo Hospital 2 years back. He presented with similar symptoms and was managed for intraventricular hemorrhage, secondary to uncontrolled BPs. Maybe the only important thing in the family social history is that he has a paternal familial history of hypertension. So at emergency, when they did the primary survey, his airway was open, it was patent, he was able to talk. He was breathing at a respiratory rate of 18 cycles per minute. His saturation levels were 97% on room air. His chest was symmetrical, there was equal air entry, normal breath sounds, normal sounds on percussion. Okay. Circulation, he had a normal JVP, no pallor, no edema, normal pulse rate. It was a full volume. However, his BPs were quite high. He had a systolic BP of 203 and a diastolic BP of 137. Capillary refill time was less than 2 seconds. So at emergency, they intervened with IV labetalol 20 milligrams, given every 20 minutes until the BP was less than 160 out of 90. In addition to that, they took off samples to do a CBC, RFTs, lipid profile, and RBS and serum electrolytes. When we come to the disability or the drugs that were given,
Thank you.
Yes, Daniel, you can proceed.
If we have the slides here, we can
Okay,
present the case.
okay, Daniel is back. All right. All right, Daniel has gone off, but we'll proceed with reading the presentation. That disability or drugs. A patient was anxious and restless in pain. He was oriented in time, place, and person, and the no focal neurological deficits. Noted GCS 15 out of 15. The tone, power, and reflexes were intact for both up and the lower limbs, and his random blood sugar was 6.1 millimoles per liter. When recommended BPs were achieved, the plan was to initiate oral amlodipine, 10 milligrams, temlisatan, and 80 milligrams, then oral atorvastatin, 20 milligrams, then oral trap, 50 over 325, and then exposure. The abdomen was of normal fullness, soft. There were no palpable organomegaly. Non-contrast CT, they noted noted non-contrast CT scan of the brain that demonstrated a hyperdense region, an acute hemorrhage in the right cerebral hemisphere with, please scroll up. They noted the non-contrast CT of the brain that demonstrated a hyperdense region, an acute hemorrhage in the right cerebral hemisphere with surrounding white matter hypodensity consistent with vasogenic edema. And let's continue. A follow-up after 30 minutes, the patient's breathing, respiratory rate was 20 cycles per minute. That's equal chest expansion, normal air entry bilaterally, and SpO2 was 98 on room air. His circulation, the BPs are now 156 over 103, and the pulse rate was 83, with CRT less than 2 seconds. And the plan there was to stop labetalol and start the oral meds. The patient reported reduced headache, but was still complaining of dizziness. The abdomen was of normal fullness with no obvious abnormalities. All right, Daniel can take it over from here. Hello, Daniel, can you take it over from here? All right, so the patient's signs and symptoms, there's a severe headache associated with dizziness and blurring of vision. The patient had no allergies and was on antihypertensives and atorvastatin with poor drug adherence. The patient's past medical history what was important was he was a non-hypertensive, and this was his second admission with similar complaints. And his last meal had been the previous night, supper, and then the events, the patient was at work. On the first day, these symptoms presented and progressively increased in intensity until the day of presentation. He had no history of trauma. So continuing forward, an examination, the patient was middle-aged, anxious, and restless in pain, not in obvious distress, with no jaundice, no anemia, no lymphadenopathy, was not dehydrated. The peripheries were warm. On CVS exam, the cup refill was less than 3 seconds. The pulse was present, regular, and heart sounds 1 and 2 were heard with no added sounds. Per abdomen, there's normal fullness, moving with respiration. It was soft, non-tender, no organomegalies appreciated. Respiratory system, the respiratory rate was 18, the trachea was central, bilateral equal chest expansion and air entry, no more percussion note, chest was clear. The CNS exam, patient was oriented in time, person, and place, with pupils equal and reactive to light. The neck was soft, no focal neurological deficits. The GCS was 15/15. Tone, power, and reflexes were intact for both upper and lower limbs. Going forward, the patient's problems were the uncontrolled BPs, severe headache, and the dizziness. Daniel, are you able to unmute now and take it over from here? So the patient follow-up, the non-contrast brain CT, noted non-contrast brain CT demonstrated an acute hemorrhage in the right cerebral hemisphere with surrounding white matter hypodensity, consistent with vasogenic edema. Review by physician recommended tighter blood pressure control and added nevabolol 5 grams, but with a target map of greater than 65% and emphasized drug adherence. Follow-up BPs 142/92, then 133/86, then 128/84. The patient reported gradual reduction in headache, with very mild headache, with no dizziness or blurring of vision, reported on discharge. So the repeat CT was recommended on the next review via the neuro clinic. Okay. Daniel, are you able to unmute again? Unfortunately, we can't hear you, Daniel. Let's proceed. Let's proceed. Just maybe to sum it up for those that maybe got some problems along the way, we had a middle-aged male that was a non-hypertensive who presented with a poor adherence, and the patient had headache, and the patient was managed acutely with the labetalol to control the patient's blood pressure, and we saw the the CT, the head CT, showed cerebral edema, and the patient was managed until the blood pressures were controlled, and then was discharged on oral antihypertensives with emphasis on drug adherence. So with that, I would like us to get into any reactions to the case presentation. If there are any questions, particularly about this patient, not delving deep into the management as we prepare to get the presentation on the different causes of headache from Dr. Wamala. So if you have any reaction to the case or any question about this particular patient and how they were managed, you can send a chat, or you could raise your hand and you will be unmuted. Okay, all right. Let us hear from Moses Okot. If you can unmute Moses Okot.
Yes, thank you so much for the wonderful presentation. What I would like to inquire from the presenter, because according to the results of the CT scan, which showed a hemorrhage in the brain, I don't know if this patient did not have any neurological symptoms or presentation, much as the patient had the scan, the CT scan, which is abnormal. Thank you.
Okay, all right, we'll take one more and then Daniel can respond to that. We'll take one more from Brian Arube.
Yes, I thank you for the presentation. I think I had the same question like him. I was just inquiring about any CNS symptoms from the patient which were directing towards the stroke.
Okay, all right, thank you so much. Daniel, I hope you got the question. And if you could respond to that. We also have a question in the chat. How was the weight, BMI, and the results from the lipid profile? Was he on atorvastatin? Thank you. This is from Drake. I think the patient was on atorvastatin. Right? Yeah, that was reported. The patient was on atorvastatin. Response from Daniel regarding the neurological deficit. The patient did not have any. And then, how big was the hemorrhage? Was it small or big? So we are a little behind time. Daniel will respond to this in the chat. I will we shall go straight to the presentation on the different causes of headaches by Dr. Wamala. Yes, over to you.
Thank you very much, David, for the opportunity. I'm glad to be here once again in the hot seat. So maybe just a small comment about the patient. So this is actually a very common presentation these days. Young people, both male and female, are getting a lot of stroke. This patient had got hemorrhage some time back and was admitted. Is it in Mengo? Nsambya hospital, somewhere because of hemorrhage still. So what we need to do is to fight as much as we can to know what is driving this hypertension. Yes, he might be getting amlodipine and telmisartan, but if we have not sorted out the driver of this hypertension, we may not achieve much. And then he also had blood vision, so it would also have been good to do a fundoscopy and we see what is inside his eyes. So straight to my presentation. My presentation is causes of headache. Why is it important to know the cause or the mechanism or the process leading to headache? It's because it enables you to know how to interrupt the what? The disease process. So you get to know what interventions can work and what interventions cannot work in that particular patient. So it's very important to know the cause. In the introduction, headache is very common, as you all know, and it's among the most common disorders of the nervous system, as per WHO. And headache it can be disabling. In Uganda, there was a study done by Sachal in 2019 and colleagues among HIV positive patients who had in Rakai, and they found out that actually the prevalence or the burden of headache in that patient population was 28%, which is significant. And among these patients, 19 of them met the criteria for migraine. A number of them had functional impairment. The headache interfered with their functionalities. So all this shows that this is a very important problem which we need to effectively address. Next slide. So headache is classified into two, primary and secondary headache. Primary headache is headache which occurs, but without a clear and identifiable organic cause. And then secondary headache is one where an organic cause can easily be identified. So, but it is better to take every headache as secondary until proven otherwise, because you may say person has a migraine, yet they actually have a brain tumor. So you have to be very careful before you label someone to have primary headache. Continue. Right. So for you to pick the cause of the headache, there are some things you have to remember. Don't forget that you should always endeavor to understand who your patient is. Yeah? Are they male? Are they female? Are they elderly? Are they teenagers? Yeah? You need to understand the symptom. And in this regard, the headache. Yeah? You need to take time and understand this headache. Yeah? Let the patient describe it to you so that you understand the symptom and the associated symptoms. You need to understand the patient's past medical history. For example, in our case presentation, the patient was a hypertensive. So you need to understand what has happened in the past to this patient. You need to understand the drug history. Patient may be on anticoagulants and then comes in with a headache. You need to ask yourself, are these anticoagulants, could they be related to this headache? Maybe it's bleeding in the head. You need to understand the family history, especially some primary headaches can have familial tendencies. You need to understand the patient's social history. What does your patient do? What do they take? Do they take drugs there? You need to understand the signs in the patient, that is on physical examination, and you need to understand the investigations which you have done. If you understand all of those, then you'll be able to identify the cause of the headache, and then you can effectively interrupt and manage the patient. Next slide. So in the head, there are some structures which are highly sensitive to pain, like the scalp Yeah? The middle meningeal artery is very sensitive. The durovenous sinuses, the meninges, that is the falx. And then, okay, next slide. So those structures are highly pain sensitive. And then we have structures which are pain insensitive. Yeah? Like the ventricular ependyma, that is the cells which are lining the ventricles, the choroid plexus, which is the factory of the CSF, the pyoveins, and much of the brain parenchyma is highly insensitive to pain. So very important that you know this. Next slide. So they are what we call headache red flags, which mean things which, if they are present, you shouldn't brush them off, just like that. For example, a patient comes with a headache and has other systemic symptoms like fever, weight loss, myalgia. Patient has risk factors like HIV, cancer. Patient has neurological symptoms, focal weakness. Patient older than 50 years. Don't diagnose them with migraine. It is rare for migraine to come in at such an advanced age. Continue. Headache which is abrupt onset. You examine the patient and you see papilla edema. Headache which is positional, worse on lying down, better sitting up. Headache which has changed the pattern. So all of these are red flags. You see one of them, please take time and exhaust it. There could be something organic which is causing that headache. Next slide. So I'll begin with the causes of secondary headache. We said secondary headache is headache with an identifiable organic cause. So the causes range from infections like meningitis, could be carcinomatous meningitis, that is when cancer has spread to the meninges. Could be hemorrhage, like in our patient, and the hemorrhage could be subarachnoid, could be subdural, epidural, intracerebral. Next slide. This slide is just reminding us about the scalp and so you can see the skin on top, then the aponeurosis, then the bone and the meninges. Next slide. So this slide is showing us one of the causes of brain hemorrhage. That is an aneurysm, the balloon you're seeing there. Next slide. This slide is showing us the various types of hemorrhage which can occur. We have the epidural, intracerebral, subdural. Next slide. Cerebral venous thrombosis, posterior reversible encephalopathy, reversible cerebral vascular, all these are causes of secondary headache. Continue. Temporal arteritis, especially in the elderly, dissection of the carotids, bleeding in the pituitary. Continue. Tumors, and then a condition called idiopathic intracranial hypertension, common in young obese females who are using contraceptives. But before you label this to the patient that has this, you have to rule out other causes. Next slide. This slide is showing the brain tumors and the possible locations. So you can imagine what that person will be feeling. Next slide. And then nerves can also be a cause of headache, like the trigeminal nerve, the occipital nerve, eye problems, ENT issues, metabolic issues, all those would be causes of headache. Slide. And then primary headache, the most common ones are migraine, and then trigeminal autonomic cephalgias. The common there is a cluster headache, and then the tension headache. Continue. Migraine, more common in females, starts in childhood, usually has aura or prodrome. So the auras could be flashing lights, could be altered sensation in one part of the body. Next slide. And then after that, the patient gets a headache. It's usually unilateral, it is pulsating, associated with nausea and vomiting. Photophobia, so patient want to be in a quiet, dark place. Next slide. And then cluster, which is more common in men. This one usually begins in adulthood, and it occurs around the orbit, very sharp, lacinating, and burning. Patients are very restless. Next slide. And the thing which is interesting here is that being restless actually cools down the pain as opposed to migraine. Next slide. And it's associated with autonomic symptoms like tearing of the eye, nasal congestion on that same side, where the patient is feeling the pain, ptosis, sweating of the forehead. So these are very important symptoms to ask for when you are assessing for such a headache. Next slide. And then lastly, the tension headache, which is like a band around the head. It's very common. And it's not accompanied by nausea, vomiting, photophobia, not aggravated by movement, but patient just complains of a band around the head, and it's usually bilateral. Next slide. And then lastly, and this is just a picture to help us remind us where these headaches usually occur. You can see the tension headache is bilateral. It's like a band around the head. Migraine, usually unilateral, though sometimes can be bilateral, but many times it is unilateral and it is pulsating, throbbing. And then the last picture is a cluster headache, which usually occurs around the orbit. So this is my last slide, and I'll stop here.
Right. Thank you so much, Dr. David. He has shared with us. He has shared with us the different causes of headache, right from the primary headache, the secondary headache, and he has given us the things that we have to always remember when we meet patients that come complaining with headache, and the different things we should think about in the different patients in terms of what could be causing this particular headache. So with this, we have some time to take one or two questions as before we go to the next presentation, which is about assessment and investigation of patient with headache by Dr. Mary Ellen. So if you have a question about the presentation, you can just raise your hand, and is there any question regarding the presentation?
Someone is asking where hypoglycemic headache falls, and I see an answer already there. Metabolic, so it falls under metabolic, and there are other conditions which fall under there. So hypoglycemic headache falls under the metabolic causes of headache.
Right, thank you so much. Then there is one more question. Does cluster headache occur during a specific month of the year? From Ibrahim.
Yes, so thank you for the question. Cluster headache can have a circadian rhythm and a circannual rhythm. So it can actually follow a pattern. Maybe every summer holiday, you may find that someone gets these attacks of headache clusters. So yes, it can have a pattern. It can follow a pattern.
Okay, all right, thank you. To make sure that we keep time, we shall move over to the next presentation on assessment and investigating a patient with headache. Over to you, Dr. Daniel.
Thanks very much. So in terms of, so I just wanted to talk a bit about, so we've gone, thank you very much, Dr. Wamala, for this comprehensive differential diagnosis, right? So someone comes into us and says, they present because of a bad headache. And these are, you know, and I work in emergency medicine, so it's usually a severe headache that makes someone come in. But in general, even in a more clinical rather than specifically emergency setting, a mild headache doesn't usually drive people to the doctor. So we'll focus today here is primarily on severe headaches, or a headache where there's something about it that worries the patient enough to come to the doctor, right? I had a headache earlier today. I did not go to the doctor, right? It's the headaches that make people come to the doctor, obviously, that we want to focus on here today. And in general, as mentioned, we think of primary headache syndromes and then secondary causes, right? If it's a primary headache syndrome, the headache itself is the issue, then we have these different categories. We can treat the headache and have the patient move on. What we're really most worried about with a potential headache are these secondary causes, right? Is this a headache that's being caused by intracranial bleeding? Is this a headache that's being caused by a cervical artery dissection, by temporal or giant cell arteritis, right? So with this, as I say, with this excellent differential diagnosis in our head, the patient comes in and sits down in front of us, and how are we going to start parsing what's going on, right? So the first thing that I think about is trying to sort whether or not this is a primary headache or a headache to a secondary cause, right? So our primary headache syndromes are the tension headaches that we mentioned, the cluster headaches, a migraine headache, whether the patient carries a specific diagnosis of migraine or any recurrent chronic headache, right? That's sort of the migraine syndrome. And then another important primary headache syndrome is a medication overuse syndrome, right? So if someone is regularly using a pain medication of some sort, especially to treat a headache, overusing that medication can itself lead to a headache. These are very difficult headaches to deal with patients because it takes a lot of counseling on how best to manage them. But those are the four primary headache categories of primary headaches: tension, cluster, migraine, and drug overuse. Yes. So the first thing that I want to think about is what these secondary causes are. And as Dr. Wamala mentioned, that means looking immediately for red flag syndromes, right? Any kind of red flags that's going to immediately make me dig a little bit deeper and worry about the headache that's in front of me. Yeah. So any headache that is of new onset, if this is a brand new headache, this is not somebody who gets headaches recently, but they've just got like a terrible headache, and this is a new phenomenon, I'm already a little bit more interested, right? Because people who get cluster headaches, people with migraines, even people who regularly get tension headaches, this is not a new thing for them, right? It might be bad enough today that they came in, but having a bad headache is not a new thing. So somebody who's presenting with a brand new phenomenon of this headache, I'm worried about. I'm very worried about any headache that was sudden onset. Yeah. I mentioned that I had a headache earlier today. I didn't sleep. I didn't sleep much last night. I'm a little dehydrated, blah, blah, blah. So my head started bothering me a little bit earlier. And then I noticed later it got worse and it just kind of kept getting worse. And I was like, finally like, and I took some medication for it. That was not a sudden onset, right? There came a moment where I thought, I have a headache. And then a few moments later, I thought this headache's getting even worse. And I finally broke down and found some paracetamol, okay? The headaches that I'm really worried about are the ones that are boom, yeah? We call them thunderclap headaches because you are living your life and all of a sudden, oh my gosh, right? All of a sudden you have a terrible headache. We often in emergency medicine talk about the worst headache of your life. If this is your first headache or your worst headache, I want to hear about it and I'm worried. And we're specifically worried about this, if it's the worst headache of your life and if it happened suddenly, right? So the headache that I had earlier today, I had it and it got worse and worse and worse as time went until I finally broke down and took some medication, as opposed to a category of headache that's like, just suddenly it's like terrible in a like 1 to 2 minute time frame, right? I mean, it might start to get a little bit worse, but within 1 or 2 minutes, it's like incredibly bad. And maybe it stays horrible and maybe gets a little bit better over time. That's that sudden onset or thunderclap headache that we worry about, yeah? And what we're worried about there is that that might be a ruptured aneurysm, right? That might be a subarachnoid hemorrhage. And that can happen absolutely out of nowhere, you know, for a patient can just be sitting at their desk and it can happen, or it might happen during activity. There's a whole phenomenon in emergency medicine of subarachnoid hemorrhages that happen during sexual intercourse, right? You're like all revved up and then your head just explodes with the worst headache of your life, right? So it can be brought on during a time of intense activity of some sort, or it can just happen spontaneously. But again, red flag, worst headache or first headache. I'm a little bit worried about that, right? The other thing that we worry about are what we call hard neurological signs, right? So soft neurological signs are like, I just don't feel well, or I'm kind of dizzy in a general way. I feel a little fubby headed. When I have a terrible headache, I feel like I'm not thinking very well. Those are more general headaches. Now, none of this is absolute because the gentleman that we just got the case presentation on, he had generalized symptoms, right? As I recall, I think he came in with a headache with some dizziness and some vague things like that, and not really a hard finding. So none of this is absolute. But if somebody does come in with what we call a hard neurological finding, and that is, say, not being able to move a body part, right? Even a small one, somebody comes in and they're like, they've noticed their right arm is weaker than their left arm, right? So a focal, one body part more than the rest of the body, a focal neurological finding, very worried about that, right? Because that will suggest any kind of geographic symptom like that, one part of the body instead of the other, could suggest a stroke, right? That something's gone wrong in the part of the brain where that particular body part functions, right? So hard neurological finding is going to be anything specific to a body part. And along those lines, any cranial nerve deficit, right? I once had a pregnant patient who came in and she said, my right cheek is numb. I'm like, what? This one, she could draw it, this one little area on her cheek was numb. And like, okay. But she noticed it and she came in and sure enough, that woman had a small but detectable stroke in the little part of her brain that handled sensation to her cheek. So that was her, but that counted, that we sent her immediately for imaging because she had one part of her body that had a symptom, a motor or sensory symptom that the rest of her didn't have. And at the time we were kind of like, not that impressed with this woman coming into us because, you know, her cheek was numb, but hey, she had a stroke, sure enough. So that's a hard neurological finding. Any body part that's, you know, has motor or sensory deficits that the rest doesn't have. and the first and the worst. And the other one that we worry about specifically, which is along those lines, is ataxia, right? Somebody comes in with a terrible headache and they're veering to the left or the right. There's something wrong with their gait, with their walking. I'm worried about that as well, right? So those are the things that just in the quick interview with the patient, those are some of the red flag signs that I'm looking for, right? One of the most important things that I probably should have said first is the first thing I do when someone comes in is try to get some pain control, right? You are not going to be able to have a really involved history, a conversation with a patient who's miserable, right? So there's nothing keeping you from offering some pain medication right away to help a patient feel a little bit better while you try to parse what's going on, right? So if you can offer some pain medication and then look for these red flag signs, yeah? The other things to keep in mind there's two populations we think about in particular. One is the elderly. With the elderly population, they have a much higher likelihood of having that temporal arteritis or that giant cell arteritis, right? And so I literally, if I have a patient, they don't even have to be particularly elderly. They don't have to be 90 years old, just, 60 and above or something, just sort of on the older side. Then I want to ask, they're going to have a painful, maybe even noticeably enlarged temple area. They may be having difficulty with their jaw. Those are patients I'm extremely worried about. And if I have a patient who's over 60, who says, ouch, when I press on their temple, 60 to 80 milligrams of prednisone immediately. They can lose their vision sitting right in front of you. I immediately give high dose steroids while we sit back and figure out what we need to do. That prednisone is not going to mess up the biopsy that you may be sending that patient for. And then the other patient that I worry about a little bit, the young patients, people that you think of as being too young for a stroke, if they can have what we call cervical dissection, right? And it doesn't take much trauma. Yoga classes can even cause it. In a young person, you can get a dissected cervical artery or vertebral artery, and those headaches tend to be intense and have some facial pain associated. So a young person with an intense headache and some facial pain was maybe recently gone to a chiropractor or had some kind of physical activity. I think about the cervical dissection, right? So that's my approach. The patient comes in, they're in pain. I try to relieve their pain some. I look for red flags. If it's an elderly patient, I want to think about giant cell. If it's a young patient, I want to think about the possibility of the cervical or vertebral artery dissection. And if none of that is the case, then we are much more likely to be dealing with a primary headache. In which case, if it's a cluster headache, high dose oxygen, right? If it's a migraine, we can do some fluids, we can do some dopamine antagonists. I'm going to talk later about how to actually treat headache syndromes. But that's my approach. First I want to know, is it primary or secondary? How worried do I need to be? Yes. So if you can just remember first and worst, that's going to get you a long way to getting those things. And quite young or quite old, I would worry about that as well.
Okay. All right. Thank you so much. That has been a comprehensive presentation on assessment. Just to recap, when we receive the patient, we have to look at managing their pain as we try to do the primary survey, and then we have to look out for the different red flags in the patient, taking note of their age, because it's a big pointer towards what we are managing here. And then we get to think about the different causes, and then we go into management, which is going to be the next presentation after Sister Diana. So we are a little caught up on time, but I will allow for 1 or 2 questions. If there is someone with a burning question, just raise your hand, and then we shall take a question regarding the assessment and investigating a patient with headache. Any questions?
Okay, let's see if we have any in the chat.
Okay, all right.
No questions, huh?
Yeah, there is no question for now. Is there a hand up? Oh, all right, Arik, let's listen to Arik, and then we shall respond to his question, and then we shall have a presentation by Sister Diana on nursing a patient with a stroke. You can unmute. Can be unmute, Arik.
All right. Yeah, thank you, doctors, for a very informative session. Doctor, you emphasized the importance of alleviating pain. What is the initial pain medication do you offer before actually knowing what is causing the headache? Do we blindly give painkillers?
That's fine. Yeah, that's a good point. You can sort of quickly even before I give pain, but my first question I always ask is to describe the headache, and I want to know if it was sudden onset, if it was at its worst the moment it happened, or if it was bad and then got worse and worse and worse. I ask that question as I'm walking up to the bed, practically, right? That would tell me if they're giving me and it was worse right at the beginning, then I'm probably not going to give, say, an NSAID like an ibuprofen or something, because that can, you know, kind of affect something. If I'm concerned there might be a bleeding that's going on, right? But I can't think. You tell me if I'm missing something, Dr. Wamala. I can't think of a counterindication to giving like some paracetamol right away. We often give the dopamine antagonists like the metoclopramide, chlorpromazine. I'm not sure what's commonly available here. And you can always give us an opioid of some kind, right? You're not going to, there's no contraindication for the things that we're thinking about to give, if needed, a little bit of an opioid to help with it. So I would probably give one of the antiemetics, that class of drugs, and we have IV paracetamol here, which is wonderful. We don't have it where I usually practice. And even some IV fluid can often help with pain.
Okay, all right, thank you so much. We can keep sending in questions via the Q&A or via the chat. They will be answered as we move along with the presentation. We shall go over to Sister Diana to present nursing a patient with a stroke.
Thank you. I'm going to take you back a little bit from our case presentation. The patient we are managing was admitted the second time. And from the history that was given, there was poor drug adherence. So it came to my mind at the time of discharge during the first admission. I don't know if the nurses did their work or the nurses were involved, because we nurses spent most of the time with the patients. So after the doctors have made and the patient's condition improved on time of discharge, this patient had to be cancelled to change lifestyle, the do's and don'ts. So you might find why this patient was admitted again. There are certain things he didn't stop doing and he continued doing. That's why he was admitted again. So this brings us to, as we are managing these patients, it's teamwork. It involves the nurses, it involves the doctors, it involves the physiotherapists and other groups of people. Okay, so back to the main issue. When we are nursing stroke patients, mainly we nurses, we use what we call the nursing process. It's a tool we use when we are managing patients, yes? And it has steps that we follow. It has 5 steps. In them, we have assessment. From the assessment we develop our nursing diagnoses, and then we plan on how we are going to manage, we implement, and then after we evaluate to see what we've put in place, has this patient really achieved much? And you will find we develop a nursing care plan for each patient. So it's individualized. It might be stroke, but then you find these patients have different needs. So when you're carrying out your assessment, maybe for a stroke patient, it might be the stroke would have affected half, or it could be partial or full, covering both sides of the body. So if it's really hemiplegia, yes, you can talk to the patient and you can obtain some data from the patient, what we call subjective data during assessment. And you add on the objective data you obtain as you're assessing the patient, then you put it together and you can develop your nursing diagnoses. Yeah. So as we are saying there, we are saying that typically, as you are managing these patients, it's a comprehensive evaluation. And here we are looking at the neurological, cardiovascular, respiratory, and muscular. You assess all the systems to really come up with the right information, because whatever you get during assessment is going to guide your management. Yes? So we will look at the cardiac system, and here we will monitor our vitals, which involve the blood pressure, pulse. We look at the MAP, respiratory rate, and the saturation, the oxygen saturations. And here you will be able to detect, when we are managing stroke patients, especially if the whole body was affected, you can get, you can know that a patient has a problem much of in body language, looking at how the patient is presenting. You can see the face expression, then you know this might be this. As you're taking your vitals, then you can really weigh at this time, this patient needs this. So with our vitals, we can be able to detect where we're having hypertension or hypotension, because this can happen to a stroke patient. At times the pressure can rise, then at times it can go down. Then you can get to know at this particular period, what can I do? Is it positioning? If I change the patient's position, will the BP stabilize? Then we can use our ECG for the heart to detect heart arrhythmias, the capillary field. Yes. Then with the respiratory function, will you observe, is my patient using accessory muscles when breathing? Are they shallow breaths? Is the patient breathing very fast? Because this can really tell you whether you're having a respiratory acidosis, metabolic acidosis, depending on how the patient is breathing. Then you can look at hypoxia. We can do the arterial blood gases, because this can really guide you. Next. Then the neurological function, as I said, you go on assessing system by system. And with the stroke patients, it's very, very important for us to always carry up the glycoma scale assessment. Yes? And this is something we usually do every day, because you can find a patient that was at a score of 14 out of 15, the next day is at 4 out of 15. Something could have happened. So it really guides you on what intervention you can do at that time. Yes, and what to give. So in our BCS assessment, we look at the best eye opening, which is scored out of 4. And here, if the patient can't open their eyes, you score 1. If the patient only opens the eye responding to pain, we give 2. Then if a loud sound, you make a loud sound and then the patient opens the eye, you give 3. Then if the patient opens the eye spontaneously, then that's a score of 4. Then best verbal response, If no verbal response at all, that's score 1. Incomprehensible sounds, score 2. Inappropriate words, like the words are not really coordinated. 3, very confused. 4, and if the patient is oriented, whatever we're asking responds back, we give a score of 5. Then best motor response, no motor response at all, it's 1. Abnormal extension to pain, you know there are some reactions you expect, but then you inflict the pain, then the patient does the opposite way, score 2. Abnormal flexion to pain, 3. Withdraw from pain, 4. Localizing pain, 5, and then obeys command 6. Then we go to the sensory functions, because stroke usually, it affects the nervous system. So you will find most of the sensory organs are really affected. And one of them are the eyes. So you will try to assess for the visual field deficits, double vision, hearing loss, tinnitus, numbness, tingling, vertigo, unsteadiness, temperature, alterations in skin integrity, then you look out for edema. For the GIT, you can assess for any abdominal distension. Is the patient vomiting or reporting any vomiting? And the bowel sounds, is it hypoactive? Then for the renal system, you really look out for the input and output. You can look out for hematuria. Then after the assessment, you can do some tests. These can be prescribed by the managing doctor. There we can do the CBC, the serum electrolytes, blood glucose, and platelet count. And then from all that you've assessed, you can be able to formulate nursing diagnoses. And amongst the few that I thought of, we have the inadequate cerebral perfusion. There is impaired ability to communicate, impairment in physical mobility, altered sensory perception, inability to perform daily living activities. Next slide. Impaired swallowing, ineffective coping, and impaired body image. So from the nursing diagnosis I've talked about, you can prioritize and see which one is major that you should manage first. Yes? Then in our management, we usually try to avoid complications that might arise from the condition the patient has, stroke. We don't want the patient to become worse than before. So we try to look out for all that can complicate the patient's improvement. And in so, if a patient is vomiting, you know that it's a stroke patient. This patient can't, most of the muscles are relaxed. So you know there is a risk of aspiration. So to avoid this, the patient can be positioned in a sitting up position. Then instead of feeding by mouth, an NG tube can be passed. Then if the patient has seizures, you know we are at risk of falling. So they are better managed in beds with rails. Yes, and then we go to the interventions from the assessment and the nursing diagnosis. We now go to what can we do for our patient. Yes. So with the neurologic dysfunctions like level of consciousness, the motor and sensory deficits, the vital signs, we can raise the patient's bed at an angle of 30 to 45 degrees. Yes. And We can position the patient to prevent the risk of aspiration, improve on breathing, improve on the SpO2. Then we can do the 2-hourly turning. We can treat the pressure areas, prevent the patient from developing bed sores. We can do passive exercises for the patient, and this helps to prevent the contractures, DVT. Then we can use pillows, cushions to really position the patient in a position you want, because the patient won't be sleeping in spine all the time. So we can do lateral positions, but to maintain the patient in such positions, we use the other accessories like pillows and cushions. Then we assist with rehabilitation and therapy. Here the physiotherapists can come in, the speech therapists, because you can find this person, and this person is recovering. He has to learn again how to speak and do certain things. So these people are also involved, and you work with them. You also teach the attendants how to do the exercises if the other people are not around. Then on top of that, we also administer our medications as they are prescribed by like the way the doctor made a prescription. You give them in time. Yes, you ensure the patient receives the fluids, the feeding, the output is recorded well, the input, and it's balanced. Because at the end of the day in the morning, when the doctor comes in, you have to explain how the patient was the whole day. So you do most of the work for the patient, document, and then you share what you found with the doctors, because there are some things they can miss and you note, and then you tell doctor this and this happened, that at night maybe the patient had this number of seizures and the doctor didn't see them, and this can really guide the management. And then, as you know, with the stroke, the patient's image might really change. They might recover, but will be unable to do most of the daily activities. So you have to really prepare even the family, how they are going to deal with this patient. You have to also prepare them to accept themselves. It's a process. They might recover, but after a certain period. So you really have to talk to them, the family, to be patient with to really handle the patient slowly. The patient can improve with the time, but if they are supportive, yes. My goals and outcomes, I think I've talked much of it. And the most important thing as we are discharging these patients, if they have really recovered, we really need to talk to them about what to feed, the exercises, to really come on time for their appointments, yes. And the other key thing that the patient depends on with the nurses, mostly the stroke patients when we are managing. So you think for them, you really have to be very observant. You note every slight change in the patient. You can read the patient's face and really know the patient wants this. And then you take your vitals very seriously and record. For a seriously sick patient, you can do it every 30 minutes. Because any slight change can indicate something, and you can do a timely saving if you've been following the patient very well. Yes, that's what I can say. Thank you.
All right, thank you so much, Sister Diana, for that comprehensive sharing on nursing care of our stroke patients. As we have all seen in the hospitals, the nursing care is very, very crucial for the recovery and rehabilitation of patients with strokes, and the nurses are our heroes in this. She has shared quite a lot. I like the fact that she has brought out the concept of not leaving out the family as a preacher of patient-centered care. This is one of the things that we go for, always ensuring that we do not just look at the patient, but even the people that care for them, because they're going to be a cornerstone for their recovery going forward. We are a little bit behind time. I don't know if there is any crucial question that has come up. I'll take a question and then we shall get into the presentation by Dr. Kaddu Mukasa on management of headaches and stroke. Any question about the nursing care? I like the discussion that is going on in the chat. You can check it out and see the different responses that are coming in from the experts and fellow colleagues in the field. If there is no question, I would like to welcome Dr. Kaddu Mukasa to share with us on management of headaches and strokes. Dr. Kaddu. Hello, Dr. Kaddu.
Yes, hello, how are you? Let me just get the right to be able to share. Just hold on a few minutes as people ask one or two questions.
Okay.
Just trying to put it on, yeah.
Any more questions?
Hello. Sorry for talking before I'm selected. I've been putting up my hand. This is Dr. Chiyimba Achilles, and thank you so much for sharing with us the nursing care. Something you talked about that you start engaging like caretakers, I think is very critical, especially for us who are into the chronic care after discharge. And I'm just wondering whether you ever also do some kind of assessment of where this client stays in preparation for discharge. Because after discharge, you're releasing this client to a community where they may not have a lot of access to medical care. And you want to assess it right before discharge and then start preparing them for discharge. I don't know whether you ever do that in the hospital setup. For me, I'm connected to the stroke rehabilitation hospital, and we tend to get so many clients actually who are taken direct back home, and they come to us actually when they're in very severe conditions because they were not prepared before leaving hospital. That's it from me. Thank you.
Yes, let's take that one question and then we shall move on to Dr. Kaddu.
Thank you. Basically, in our hospital settings, we don't have that program of first going to the community and trying to analyze to see what is there. No, but what we do, we usually take the patient's contacts and then the patient's contacts and the relatives, and we follow up. We keep on calling to find out how the patient is doing. And we always advise them to go to the nearby relatives, not from to their homesteads. Yes, somewhere they can easily, we can easily access them and where they can easily access us. Yes, thank you.
Okay, all right. Let me call him. Hello, Muhammad. You've shared mnemonic. I don't know if you can unmute and share with us in a minute about the mnemonic regarding nursing care. Muhammad Hassan.
Yes, thank you for giving us a wonderful presentation. And this mnemonic I came across when I was rotating in my medical school, and they were elaborating more on how we should manage these critical ill patients who have the stroke. So we are using the mnemonic, the first heartbeat in place. So the F stands for the feeding, And we actually initiate some enteral feeding for this patient as soon as possible. And as well as we address the fluids and how to prevent the fluid overload. So the F stands for feeding as well as fluid. Then the A stands for analgesia, because these patients, they need analgesics. So that actually we consider these painkillers analgesics. Then S is sedation, so that we actually sedate these patients. Then the T stands for thromboprophylaxis, so that we consider the bleeding risks involved and initiate those appropriate prophylactic treatments. Then that's the first now: feeding, analgesic, sedation, thromboprophylaxis. Then the hug, we have the hug in bed. Then the hug actually is the elevation of the head of the bed, and we consider up to 30 degrees to reduce the occurrence of this GI reflex, because these patients, they are at risk of aspiration pneumonitis. Then the U is the ulcers prophylaxis that they have mentioned, whereby we are preventing the bed sores, so we give them the prophylaxis. Then the G is the glycemic control, whereby we maintain the glucose level, the sugar levels. So that is the first hug. Then the B is the bowel regimen, whereby, you can hear me?
Yes.
Yes, so the bowel regimen actually is that we want to prevent constipation. So patients, we order them this bowel regimen, especially those who are on opioids. So we prevent constipation. Then the I is the indwelling catheters. So we put for this patient catheters, the urinary catheters, the central line catheters. Then the D is the de-escalation of antibiotics. So we tend to de-escalate antibiotics appropriately. So we base them on culture. Yeah, I think that's what I can say about the first hug in bed, which helps us in managing critical ill patient.
Thank you so much for sharing that incredible mnemonic about nursing care for patients with stroke. Dr. Kaddu Mukasa, the rights have been shared for.
Well, I'm trying to share my slide, but the host has been disabled, so I can't share unless you allow me to share.
Let's see if share it.
Doctor, you've been made a co-host. You should be able to share. Yes.
Alternatively, I can send my email. You can send me an email. The WhatsApp I send, then you can be able to put them up. That's okay.
Okay.
On our end, that you have the ability to share. Can you try again?
All right, good. Good evening to you all.
Looks perfect.
Hello, are you able to hear me?
Yes, loud and clear.
All right, so just put these things out of the way. Yeah, so I'll have a brief discussion regarding the management of headaches and stroke, in particular hemorrhagic stroke, because the case presentation was about stroke. I'll just want to reemphasize that primary headache disorders These are headaches which usually arise from any underlying medical condition, and we have a couple of them known as migraines or tension-type headaches, or trigeminal autonomic cephalgia and other primary disorders. Then the secondary headache disorders, these are headaches due to any underlying medical condition, which can rise from any either blood vascular causes, neoplasms, infections, or any intracranial changes in either volume or pressure. So I just wanted to bring this again so that we can be able to identify what's a primary headache and what is a secondary headache. Here we have some of the risk factors. It's a slide which is pointing to the risk factors. Headache usually come because of certain things. Where either patients can have headaches. Usually it can be secondary training, pain in the neck. I'm sure one has talked about it, Dr. Wamala. It could be narcotic withdrawal, either you're doing things like cocaine or marijuana. It could be any oral infection or dentition problem, abscess, or it could be referred pain or trauma. And then we could have headaches which are coming from post-surgical or post-endovascular intervention. And this could be coming from pneumocephalus or hyperperfusion syndrome, or anything which deals with the craniotomies or drainages from the brain. Then we could also have headaches which are coming from either medication or medical conditions or infection. And these are the most common that we saw on the wards, or that we experience with patients who we handle daily. Withdrawal of medications, caffeine or nicotine, various infections affecting the CNS, hypertension, then chronic kidney disease or any other related problems. And then for the types of headache, we usually have those types which have a thunderclap kind of pattern of pain. And when we think of thunderclap, we think of things like bleeding within the subarachnoid space, the subdural hemorrhage. Either we think of ischemic or hemorrhagic strokes, thrombosis of the central venous sinuses, pituitary apoplexy, and among others. The list is long. But we never take a very severe headache for just normal painful headache. So we have to think in a box that maybe there could be some other worsening conditions which are related with that. Now, which people are more prone to getting these kinds of post-stroke headaches? From the literature that I reviewed, most of the demographics look at people who are usually younger, between around 35 years to around 45 years to 55 years tend to have more of these headaches. If you're female, if you have history of any pre-existing headache disorders, and if you have headache at the onset of stroke. The mechanism we'll discuss, but they are mainly due to dissection of either artery or cerebrovenous thrombosis. Of all the patients that I've seen, those who present with cerebrovenous thrombosis tend to have a very, very severe headache compared to other kinds of CNS presentations. And we could have also psychosocial problems, post-stroke fatigue, and post-stroke depression. Here we'll look at briefly the pathophysiology and what happens. Why do we get these bad headaches? One, we know that hypertension is among the main major risk factors for getting either stroke, either ischemic or hemorrhage. And either we can end up having a rupture of a blood vessel, which blood is going to lead to the irritation of other structures within the brain. And once we look here in the small box, you see a blood vessel, and then we can have inflammatory cytokines or inflammatory mediators, which are going to lead to dilatation of the blood vessel. At the same time, we are going to cause inflammation of the coverings of the brain. And in so doing, we are going to stimulate the release of other cells, like the mast cells, to release the other components, calcitonin, G receptor peptide, which are going to help in to potentiate the effect of inflammation. And these are going to stimulate more pain within the brain. Then we have other proteins, which are matrix metalloproteases, which are going to also stimulate other inflammatory substances. In relation, once you look at this structure of the brain, we have the trigeminal nerve, which essentially traverses the brain, the part of the frontal area, and it's good in sending back senses or pain senses to the brain. So anything, once it comes in contact with these mediators, you can see how we are close to the cervicogenic vein, which are going to release mediators, and these are going to affect the nerve. Then other things, you have raised intracranial pressure, which can lead to or low intracranial pressure. We can have any tears in the vertebral artery or any ruptures in the aneurysm, and these are some of the reasons why you get a severe headache, okay? So we always get headaches. I'm sure all of us, at least 99% of us, by the time the year ends, everybody has experienced a headache. But we never worry. So when should we worry? So if a headache, or when you start developing headaches beyond the age of 50, then you start worrying, how come these headaches are presenting at this time and they didn't present at an earlier age of maybe 20 years, 30 years, or 40 years? If you have a major change in the pattern of the headaches, there are headaches which we get and it has a special pattern, or afternoons when you've been stressed during the day, then you can get a headache. But this time you can be woken up by a headache at around 3 a.m. in the morning, or you get a headache in the morning, slept well, everything is okay, but then you get a headache. As opposed to headaches which come before lunch, maybe somebody is hypoglycemic, or is stressed, or after a long travel, then we can be sure that probably these headaches are related. But once you have this change in pattern, then you start to worry why these are happening. Then unusually severe headache. So this will do by grading. There are times you get a headache and you can continue doing your own work. You can drive, you can do some reading, or you can even sleep, and the headache is minimal. Or music can be booming in the background, but you're able to contain the headache. Then headache, which increases with coughing or movement, usually can signify that we have something like an increase in the intracranial pressure. Headache that gets steadily worse. It's like a step ladder pattern up, where you have an increase in the headache maybe after 2 days, it increases. We've seen like headaches which come in cryptococcal meningitis, where we need to tap that. It starts as a small headache and it keeps on increasing in intensity until the patient cannot take it and you have to tap. Then headaches which causes change in personality or mental function. The list is endless, but I picked out a few things just to remind ourselves which headaches are more important to worry about. In some literature, you'll find this as the red flag signs. which tend to stand out of the normal headaches. Now, how do we approach a patient who has had a headache? First step is to take headache history. Here the previous speaker who was presenting, she talked of you have to know the frequency, what part of the head is affected, how often does it occur, what's the character, what's the nature? Is it a throbbing headache? Is it a band-like headache? Is it piercing headache? So you want to know all these in your history. What associations, accompanying symptoms are associated with this headache? Does somebody feel dizzy? Do you feel like vomiting? Are there fortifications, seeing like stars, or are there sometimes having loss of vision? Do we have any seizures? Are there any other abnormal or loss of power on any part of the body, arms or legs? So we want to associate all these symptoms so that it can be able to guide us and give us a proper diagnosis. Then we have to do a thoughtful physical examination. Thoughtful physical examination will start from our eyes. Are there any changes of ophthalmic changes that the patient notes or the person examining notes? A fundoscopy is very important. We have to look at the pupils. Are they the same diameter when on examination, or there is a difference that maybe they might be unequal, or they react differently to light? These can sometimes give us a hint to what's the problem. Is there a papillary edema, or is there any raised intracranial pressure, depending on the pupillary sizes? Then you want to look at fundoscopy. Are we seeing any abnormal things? It could sometimes give us a hint on dissection of any intracranial vessels or aneurysms or cavernous sinus syndromes, which include the cavernous sinus thrombosis. Then we have to also go on and examine the cranial nerves in combination, especially cranial nerve 2, which is the optic nerve, cranial nerve 3, oculomotor. We combine 3, 4, and 6, oculomotor, abducens, and trochlea. These give us a hint on which part of the brain has been affected in terms of are we having any masses which are causing any raised intracranial pressure to cause isolated pulses, like in the 6th nerve palsy? Are we having any signs of raised intracranial pressure, papillary edema? So we have to look at all these. And then any other neurological signs which are coming in, or the patient is presenting, that we are able to pick up. Okay. Then, having done this, we assess the pain as the patient says, or as the person suffering from the headache complains, not as you, the physician or the treating doctor, you think. Somebody could tell you I have a very severe headache. So great as he has. So this is a scale, which is, there are many scales. There is a headache intensive scale. There's a normal pain scale which uses spaces. So there are various scales which you can use, or you can use your fingers or the faces. But all in all, these scales help us to classify the type of pain and what the severity of the pain, so that the patient can be helped and to know what kind of painkiller can be used to help to reduce on the headaches. So we can see that here we have what was most severe pain to no pain. And then this will guide in the treatment of the headaches. So sometimes we are faced with challenges where patients, especially those who have had headaches for more than 2 days, 3 days, present to you and they are going to ask, doctor, I want to do brain CT scan or brain imaging. And then sometimes you are in a fix, you don't know if you should ask for a CT scan. Some of the patients receive, he has just had a headache for 2 days. And the CT scan has already been ordered or an MRI. So there are some considerations that would look at to mind if you're doing a CT scan. So if this is the first time somebody is having a headache, then we assess and see, is this the first time? Yes, we can go down here. Then we look at the clinical presentation and the age of onset. Remember in the earlier presentation, we noted that age on onset, if somebody is presenting with headache above 50 years, or even above 45 years, very severe headache, then you tend to worry. And these are the guys you want to go on and probably have a scan. So we have to put into consideration. So if the age is younger, then you think of primary headaches, that idiopathic primary headaches. And these we are talking about the migraine, the tension headaches, and especially if the neurological examination has been unremarkable. If patient comes, severe headache, it can go as long as 2 weeks, 3 months, and these patients have had headaches. But then are we having any neurological symptoms when you examine these patients? No. So if it's no, then we can come here to the atypical clinical presentation. And are there any atypical presentation or any secondary suspected headaches? If yes, and if all that this right is young, then we don't need any further workup. Okay. Then we go to above here, we see if a patient is not the first time and is having recurrent headaches. Yes, and then we see, are they episodic? Are they coming maybe every after 2 months or every after 2 weeks? Then you want to know if the answer is no. Then we come here to the chronic recurrent headaches, which are defined as having a headache for more than 6 months, and they should be more than 15 headaches, 15 times of headaches, or more than 15 days, headache-free days, which means for every day you have a headache. It doesn't matter whether you're having one frequency or many frequencies, but it should be more than 15 days. So half of the month, you have a headache. For the next 6 months, then you can say you have a chronic headache. Then you want to see, is this headache, are there any atypical presentations? Like maybe it has been chronic, but now it's presenting with some dizziness. Or there is epistaxis, or there is vomiting. Then you want to go on and scan these guys and also do a workup for various factors. Here, I think it was just a few things which were noted, but this list can also be endless. If no, and the neurological examination is also normal, then we'll still treat as a secondary headache just to do prophylaxis. Excuse. So in a few minutes, we'll be just touching or briefly discussing the management of hemorrhagic stroke, because our case was about hemorrhagic stroke treatment and management of a headache. One, we talked about the history that we are taking, we should have started with. Then classification of the headaches to know if it's a primary headache or secondary headache. In this case, it was a secondary headache, which is coming from a stroke, hemorrhagic stroke. Then would manage by determining if we are going to image, which imaging was done. Then second, would manage some of the complications of the patient who would have a headache and a stroke. And among the things we want to talk about is seizures or convulsions. Most of these patients will tend to have seizures because of either an increase in the volume in the CNS after bleed or irritation, and this is going to cause excitability within the brain cells or the neurons, and then will lead to seizures. There is no preferred choice of treatment for the anti-epileptic drug, but the rule is once we have a confirmed conversion, then we have the right to start these patients or any anti-seizure drugs. What might affect if it's intravenous or oral is if we want to control the seizures immediately, and if the patient is conscious so that he's unable to swallow, then we can start with intravenous, then later move on to oral. All other drugs, whether they are severe seizures, sodium valproate, carbamazepine, and phenytoin, and also levetiracetam, have the same efficacy. But to keep on note that all drugs have their own side effects. Like we'll use levetiracetam, it increases the risk of psychotic changes in our patients. And then phenytoin would cause some respiratory, we were of respiratory complications as we increase the dosages. So we have to mind about that. We'll skip blood pressure. We'll have a slide about it. We have to control the intracranial pressure control, because here you've had the brain is already enclosed in a non-expansile phase of casing, which is the skull. So as long as you have more bleeding, you're increasing the volume in the brain and therefore increasing the intracranial pressure. This will either lead to further complications like a headache, very severe headache, or we have a risk of even conic. So you want to control our pressure. Two drugs may need to use. We can use mannitol, which is a diuretic, to try to clear off the excess fluid, and then the conservative management, raising the head of the bed, and then trying to, sometimes you can give some barbiturates to make the patient calm down, and then we control the seizures and also a quiet environment. Okay. Homeostatic therapy, depending on what presentation the patient has. And depending on the level of hydration and all, if it's not low blood pressures, if the temperature is okay. So we also help in providing this kind of therapy so that we make the environment conducive for proper brain recovery. So treatment of anticoagulation associated intracranial hemorrhage. Yeah, here we've had hemorrhage, and sometimes either we are too tired or it's by mistake. You find that somebody has had an probably hemorrhage and still aspirin is being prescribed, and the patient is still taking aspirin or clopidogrel, which are antiplatelets. Sometimes we get hemorrhage because these patients have been through maybe anticoagulated. He has been on he has a DVT, he has been on Clexane, others have been on other new oral anticoagulants, apixaban, and they are causing more bleeding. Or sometimes you can have hemorrhagic transformation. It starts with a ischemic infarct, usually, which is big, and then as it's you try to care for this patient and all the care, then it bleeds, and we increase more bleeding. We don't forget our statins as we are looking for the things which can cause and worsen the caliber of the blood vessels. So you want to repair the blood vessels, and then invasive therapy. If the bleed is more than 30 centimeters tubed. Here, I won't say much. I'm not a neuro intervention surgeon, but ideally, when you have a bleed which is more than 30 centimeters tube, then you should have an intervention to drain or evacuate that clot, so that the aim of reducing raised intracranial pressure. And the moment you do it, the patient his GCS and other levels of being, whether functional and neurological, they improve. Yeah, so regarding the blood pressure, this is a slide borrowed from the European Stroke Society. And here we are looking at primary prophylaxis. Primary prophylaxis meaning we've not got stroke, no event, but want to control our blood pressure below 140/90 on antihypertensive drug. Okay. There hasn't been a consensus. Some recommend 130/80, but would be more comfortable anything below 140/90. Then with the topic of ischemic stroke, which we have not set down, we've talked about much today. We would only start on our hypertensive drugs if the blood pressure is above 185/110. I sometimes wonder, or sometimes we wonder, where somebody has got a stroke, even in our setting, maybe some we should avoid being over zeros. Somebody comes in with like ischemic stroke, blood pressure is 130/40, and somebody just loads him with a strong dose of antihypertensive drug. Tell me certain age, 8/100/12.5, maybe amlodipine and another drug, and then the pressure goes down. So keep in mind that for ischemic stroke, as this pressure has been high for some time, and there is an infected area which is already dead, and there is a surrounding area, the penumbra, which is still can be saved if the blood pressure is controlled. Now, this place has been used to a high blood pressure. So if you reduce drastically this blood pressure to maybe 120, even this still viable place is going to be infected. And this, when you are going to come back, the patient explains to you, doctor, I came with maybe just weakness in the upper arm and the lower arm, but now even the other side is also having problems. I'm feeling the same complaints of weakness or loss of speech. So ischemic stroke only decrease the blood pressure if it's above 185/10. And then when you are reducing it, let's be gradual. Don't be very aggressive that you want it in one day. We want to reduce by around maybe 15%, between 15 to 20% of 185, then 15 to 20% of 110 within the first 24 hours. Then after that, you can review and see how to reduce it further. For acute hemorrhagic stroke, the simplest explanation I can give that for hemorrhagic stroke, you have like a burst pipe of water. The more you let the water, the unattended repair, more water is going to splash out of that busted pipe, which is under pressure. So you want to reduce the pressure to the safe place below 140 systolic. There have been many schools of thought that maybe you can reduce the pressure to 120. But if you reduce the pressure to more than 120, studies have shown that there have been more mortality among these patients when you zealously reduce this pressure to less than 120. Okay, so above 120, we can use any drug. There's no clear drug of choice. You can use a nitroprusside, or you can use a nimodipine IV. We can use any calcium channel blockers, labetalol, hydralazine. So it depends on what's available. But once you start monitoring, please don't give the drug and move away. You could come back when the blood pressures are very, very low or they have been decreased to greater levels. So you have to be around. Then don't forget our secondary prophylaxis. You've had a stroke, you've probably healed with some few neurological deficits, but you still want to maintain this patient on a stroke, because once a stroke, the chances of having a second stroke are higher than a patient who has not had a stroke. And we know hypertension will be the one to cause us a headache, at the same time hemorrhage, and the second time recurrent stroke. So with those few words, I would want to say thank you, and I would, if there are any comments in the chat, I'll be able to comment. I haven't gone in detail because it was really adverse topic where we cannot zero down to headaches, different types of headaches and their care, or different types of stroke and their care. Thank you.
Thank you so much, Dr. Kaddu, for delving deep into the management of headaches and particularly strokes. We'll open this up for the discussion. We have gone past our time, but we shall push 5 more minutes. If there are questions, please raise your hands and I will choose people to ask. You can also type your question in the Q&A or the chat. I think Dr. Makerere has done a good job responding to most of the questions, but if you have one, or you can raise your hand right now, and then we shall have the experts respond to you. So maybe as we get the questions, Dr. Mujuni, when he was starting his presentation, he noted that we are having a lot of strokes in the young males. My question would be how your experiences have been, if this is the case where you're practicing, and what is causing this. I'll start with maybe Dr. Kaddu, and then we shall listen to Dr. Wamala and Mukasa.
Yeah, so generally, there has been an increase in stroke and also stroke in the young. So it's a two-way. We are seeing more stroke in the young and also stroke in the adults. There is definitely an affiliation with a vaccination in the adults. We are seeing more strokes in the young population. Stroke in the young, we are talking about people who are below 40, 45, or at most 49 years. I would generally say that in sub-Saharan Africa, we are seeing, we tend to have stroke at an earlier age compared to the Western community. Our strokes range, the age range is from 55 to onwards. Whereas in the Western world, it's usually from around 75 plus. So one of the risk factors has been vaccination that we received. We are seeing more clots, which are causing more strokes. And still we are having the dietary lifestyle that we are having. The middle class is also increasing. We are eating more things, KFCs, everybody wants KFC, fried chicken, chips. We are having unhealthy dietary lifestyles. We are eating a lot of salt, a lot of butter and margarine. And then also the drinks that we are taking. Most of these energizers that we are taking, Rock Boom, Horse, they have a component, like a caffeine-like component, which stimulates the autonomic nervous system. And this has led to many events like stroke. So that's all I have to comment.
Okay, thank you so much. Any comment from you?
Yes, so thank you very much. In my practice, my experience, in my unit, at least we see 3 to 4 stroke patients per day. So stroke is on the rise. Some of these patients are really young patients. Some of them don't have the traditional risk factors we know. And this worries me because it means none of us is immune to this thing. And the strokes are really significant strokes. Patients are comatose. Patients are convulsing. These days, it is rare to get a patient with just a hemiplegia and a facial nerve palsy who is talking to you. Most of the patients are unconscious, they are convulsing. So,
These are ischemic or hemorrhagic?
so both of them, if it is ischemic, they are huge infarcts. If it is hemorrhage, it is severe hemorrhage, intraventral hemorrhage, increased intracranial pressures. And so things are not good for us. So some of the causes we don't know. Like I said, some patients don't have the traditional risk factors. So yeah, there is a need to look into this issue and try to answer this question.
Okay, all right. Thank you so much. We shall take 2. Okay, yeah, there's one more hand up, and then we shall conclude the session. Daniel, Mujuni, you can unmute, and then we
Okay,
shall
thank
have
you so much.
and close the session.
Okay, thank you so much. I'm sorry about my internet connection earlier. So one of the biggest hurdles I've noticed in management of these patients is drug adherence. And drug adherence is a scope ranging from follow-up, changing the regimens, lifestyle modification. Now, in my observation so far, lifestyle modification is harder to manage than taking medicines. So it is better for the patients to be advised to have regular checkups. You can't do much about their lifestyle choices as a medical practitioner, but what you can do is advise them to see you regularly so that you can monitor how they're progressing on the treatment that you have prescribed. Thank you.
Thank you so much, Daniel. Chimba, please.
Thank you so much. Thank you so much for the presentation. Dr. Chiyimba actually is my name. I'm more into HIV/AIDS programming, but with a lot of interest in NCDs. And as I said earlier, I have a colleague who is running a hospital, stroke rehabilitation and NCD hospital in Wampeo. So I normally interact with him. And he told me that actually he's seeing a lot of stroke, but unfortunately he has very little contact with the medical doctors who normally manage this class when they are still in the acute phase. And so he says that sometimes after the acute phase, very little is actually done for these clients for the rehabilitation bit. And that these clients have to depend on other people, like I think the person who was presenting about nursing care said, they depend on other caretakers. And after discharge, some of them actually die. And so I think whenever we are talking about the acute management, we should also consider the rehabilitation bit. If they have some motor changes, maybe they can no longer help themselves physically, they start that management early. He told me the earlier you start this, the better outcomes for that client. But when you delay, usually those clients have a very, very poor recovery of their functions. And then the other thing, I think the doctor has been presenting about management.
Kindly summarize, Dr. Chiyimba.
Yes. So use of energy drinks is one of the things he has kept telling me about. That quite a number of clients actually getting stroke because of those energy drinks. Most of them he's receiving. I just wanted to emphasize that. Thank you.
All right. Thank you so much. So right now we've first spent our time. I would like to hear from Dr. Kaddu Mukasa, any reactions to the questions and closing remarks from your side.
Thank you so much. One I still want to reemphasize the need of physiotherapy. At Mulago, we still have physiotherapy, and all the patients channeled to the physiotherapy. This should start earliest because there's no, unless there's a contraindication to starting physiotherapy when the patient has had a stroke, but should be started immediately so that we help in the patient's recovery. So unless maybe he's having severe headache or he's in, let me say he has a clot which will be able to dislodge, we should be able to start physiotherapy there and then. So, however, most of the patients that we are receiving are being accompanied by their attendants who are coming from, maybe he's coming from village, he's having an urban auntie or an uncle. And as soon as he's discharged, some of these patients go back to their rural settings where there are no facilities for physiotherapy. And private physiotherapy will be expensive for the majority of patients, where a session cost goes for around 50,000. So secondly, I'll still re-emphasize the need of secondary prevention and lifestyle prevention. Educating patients about taking walks, about dieting, because there's nothing as easy as doing lifestyle intervention as doing medication. Most of these patients won't be able to afford the medications, so it's better to instill that they do lifestyle interventions, which can help. If it's smoking, you stop smoking. If it's drinking, you can stop. 30 minutes exercise is better for them. And also reducing on the cholesterol, foods which have a high cholesterol content. This will help them to have a longer mileage. Other than that, I think, thank you for the contributions. I think it has been a good presentation. Thank you too.
Thank you so much, Dr. Kaddu. We shall move over to Dr. Mary Ellen to give us any closing remarks.
Thanks so much for all the engagement, everyone. It's been excellent, both in terms of the spoken part and then the engagement with the chat and the Q&A is really inspiring. I think one of the important things to remember is that the vast majority of headaches, even the vast majority of headaches that we see in an emergency setting, are benign, right? So our job really, I think our initial job as providers is to try to parse out those headaches we really need to be worried about. Most headaches can be treated symptomatically and sent down the road. So it's really focusing your thoughts on what are those red flags, who are those patients I need to give a little extra thought, a patient like with fever and immunocompromised, things like that, yeah. And then the other thing I will say is that if there's one thing that so much research has shown over and over again, that the most important part of stroke care is good supportive care. And one thing I think we sometimes forget is I can't think of an illness that's treated by starvation. So figure out a way to get nutrition to your patients. If they can't swallow, they're going to need an NG tube, but we will often see patients go days without any calories, and that's not helping anyone.
All right, thank you so much. Back to the online presenter, Dr. Mujuni, any closing remarks from your side? All right, as Mujuni prepares, Dr. Wamala.
Yes, thank you very much. My closing remarks, just take home, is that headache is very common. When you're faced with a patient who has headache, endeavor to understand the mechanism of this headache, the cause of this headache, such that you manage them well. Consider every headache secondary until proven otherwise. Thank you.
Thank you so much, Dr. Wamala. Sister Dan, any closing remarks?
Okay, thank you. My emphasis will still be on involving the family in care, because as we health workers, we can do much, but we can't do all. So it's better we involve the family. They really get to know what this patient is going through. And if the patient is left with some abilities, they encourage. Yes, they give that positive encouragement. You can find they can do more if they are very supportive. And then, like Dr. Ellen said, that is very important. So we really have to put in something for really the body to fight back, these muscles to come back for this patient to improve. Yes, thank you.
Right. Thank you so much, everyone that has tuned in. Thank you for the active participation. A very big appreciation to our experts that have shared with us. And I hope we have all gotten something to add on to our practice as we see patients. And also the emphasis that Sister Diana has given us, that we are not only treating the disease, but this patient also has a family which is part of them. So we have to pay attention to that, and also their nutrition, the physiotherapy that Dr. Kaddu has emphasized, and not forgetting the things that we have to look out for when we receive this patient at the first instance, managing their pain, the questions not to forget, the secondary causes to always look out for, and the investigations to do. So with that, I would like us to go to the last part of this session, which is the screenshot. That's the post-test run. I hope we have all answered the post-test, so we can turn on our cameras and then we take a screenshot, and we shall call it a day for now until the next session. Thank you. I remain Dr. David Muganzi. Over to you, Dr. Ibrahim and Dr. Thomas.
Thank you, everyone, for attending today's session. We are happy to see you all the time whenever you join us. Our next session is going to talk about poisoning. So you come ready to learn about all the different poisons and how they manage them. And this is going to be in 2 weeks. As we prepare, we can turn on our cameras so that we can take screenshots. Remember the session. These screenshots are going to be uploaded to our website, and all the PowerPoints are also going to be uploaded. So if you want to access the screenshots or the PowerPoints, please just go to your Google and type EMS Echo Uganda. It's going to come, the website will come. As we do that, please let us rate the session. There are some polls that are still running. They're just talking about how the session was. General assessment, you can rate the session 1 out of 10 or 10 out of 10. And this will help us know where to improve. Team Yumbe, we are happy to see you as a team. You can wave to show that you can hear me.
Thank you.
Right, anyone with a final comment as we end? Please feel free to unmute and give a final comment.
Hope the mic goes to me. want to appreciate so much the presenters. It has been a wonderful presentation. And as Yumbe, we are very proud for such an opportunity. There's a lot of learning going on here, and I want to encourage everyone out there. Let's take this serious. Make your summaries as we're waiting for the notes, and let's put these things into practice. We are going to save a lot and a lot of patience, knowing that knowledge is power. May the Lord bless you.
Thank you, Simon. Let us wish you a nice weekend and see you in 2 weeks. We shall be doing we shall be doing poisoning. And the link to our group has been shared to the chat. If you want to join and keep updated on our WhatsApp group, is that link to join. Bye-bye, everyone, and see you in 2 weeks.